So without wasting much time, this is a Retina session that we have today, and most of the topics are surgically related, and the pattern will go like this. We'll have a talk, and by the time the next speaker comes in, probably we can have a quick one or two discussion points. And at the end, we will have some videos which will be given demonstrated by Dr. Rajesh, and we'll have a discussion. And because we got 15 minutes late, I think we can give the next session only about 10 minutes later. So we'll be closing by 12:40 hard stop. The first talk is going to be by Dr. V.R. Sharavanan. 25 minutes. How's that? You want to take it last?
Yeah, no, he's connecting the.
Okay, yeah. I'm just calling out in this sequence actually. Yeah. So we'll start with Dr. Venkat's presentation. Dr. Venkat, are you here? Yeah. Yeah, Venkat is going to talk on how do I manage a nucleus drop. He is a versatile surgeon. He does cataract also and he does VR also. So he can manage to drop a nucleus and pick it up too. So we'll go to the next talk then. You. So your topic is vitrectomy for RRD, no? Yeah. So we'll start with vitrectomy for RRD by Dr. Anirudh Tirmalai.
Good morning, everyone. At the outset, I would like to thank BOS and Dr. Karthik Mehta, I'm not sure he's there, for giving me this opportunity. I'll be talking on PPV, retinal detachment, and he specifically told me to keep it very simple, and so just videos going through the steps. Okay, yeah. So directly going to the thing. Let's start with the port placement. in your infusion, make sure that the infusion cannula is inside before proceeding with your the next step. And depending upon your condition, whether it's a phakic, pseudophakic, place your ports at about 4 to 3 mm from the limbus, and try to make a biplanar incision so as to reduce the risk of the ports coming out, cannulas coming out, trocar cannulas. And at the meantime, also look out for any scleral thinning, like in this case, you can see scleral thinning, so minimize leak later on. Once you're done that, comes the next part, which is the main core vitrectomy. If this is the case of a 240-degree GRT, if you see a case like this, I think for core vitrectomy, it's a good case because you know all the vitreous, especially a new fresh case, all the vitreous is all out, and the vitreous is almost separated out almost till the base. So you just have to do a thorough vitrectomy. It's a good case for a newcomer to try and take his hand on the core vitrectomy. Just ensure that you remove all the remnants of the retina anterior to the tear. During core vitrectomy, you can keep the setting at about 7,500 cut rate and 300 suction. This is the typical case you would probably, you probably get this case. Is it playing? The video is not playing. How do you
Play that down, there's a play button like that.
there's no cursor here. Okay. Put this. Not able to locate. Are you playing through the? It's okay. All right, I'll go. All right, let's go beyond that. Sorry, typically what you would get is a bullous RD with which is still stuck over the disc and along the arcades. So you need to normally tease out the vitreous from the disc. So go with the port, go with your vitrectomy cutter in the suction mode onto the disc, and then sort of suck it out and aspirate it directly anteriorly, avoiding, of course, going closer to the retina to avoid the retinal tissue coming into the break, coming into the pore. And then you clear up the rest of the vitreous. And none of the videos are loading. Next ಹೋಗಿ ಇದು ಪ್ಲೇ ಮಾಡಿ. No, I have saved it with you videos properly, but I don't know, can I put it directly here? ಹಂಗೆ ಕೊಡಿ. How do I get out of this? not yet loaded. ನಂದು ನಂದು ಇದರಲ್ಲೇ ಇರುತ್ತೆ. Just go to video. ಅದರಲ್ಲಿ just play video again. ಇದು ಕ್ಲಿಕ್ ಮಾಡಿ. ಇದು ಕ್ಲಿಕ್ ಮಾಡಿದ್ರೆ ಹಾಂ ಈಗ ಬಂದಿದೆ. Let me see if the video is applying. Okay. It's not coming out of the main screen. No, that's just, it's not going. Okay, thanks. So, okay, so this we have seen the video. So this is the video which I wanted to show. So you see, you can see here that the vitreous is still stuck over the posterior pole up to the disc. So the best way to go about it is go in onto over the disc and then with aspiration try to tease out the vitreous away from the retina anteriorly, trying not to go very close to the retina to avoid any inadvertent catch of the retinal tissue, and then try to cut it, and then go on to further tease it out as far as possible so as to be able to go up till at least the mid-periphery and beyond. So finish off. Once you've done that, comes the next step of membrane removals, whatever PVR membranes are there. I tend to use end gripping forceps for most of my cases, where I go directly onto the membrane and try to pick it up and remove it. But in case not, I can also use it as a pick by keeping it closed and then sort of tease it out. The other thing is you can use your endo illuminator as a counter traction to try and pull out the membrane. It's always good to try and take out the membrane in toto to avoid any PVR recurrences. This apart, then what if the membranes are subretinally? Then also you can make a subretinal, a retinotomy directly either over the membrane at the thickest point and try to tease out the membrane. Sorry for the poor quality video, I think it's okay, coming okay there. So try to tease it out either by rotational maneuvers or tangentially, and then sort of stabilize the retina. There are cases where people do it subretinal, go along, put in a cannula directly subretinally and then take the forceps under the retina. I personally have not tried that. So once all the posterior membranes are all cleared up, this is the time when I mostly use PFCL to stabilize the posterior pole. This also allows me to work anteriorly at the vitreous base without causing much flutter of the anterior retina. So the most important thing is that you create a single bubble. This is the same case with a GRT. I've gone in under the retina fold and then injecting. Always I tend to reduce the IOP to about 10-15 when I'm injecting with 25 gauge vitrectomy. And as you're injecting, try to come up anteriorly to avoid the pressure more onto the retina. Normally I do tend to fill the PFCL up till the edge of the retinal break or beyond based on the size of the retinal break. Sometimes as you're filling up the PFCL, you will see the sign where the arterial pulsations tend to come up. So this is the time when you know that the IOP is rising, and the best way to deal with it is to just come out, allow the IOP to normalize, and then go back and re-inject. So once you're done with your basic vitrectomy and injected PFCL, comes the next step, which is shaving, base shave. And as a fellow, I would advise that try to use depression as much as possible whenever you are assisting your mentors to get a hang of how depression is done. And depression is a very important part of our retinal detachment vitrectomy, because this tends to reduce the risk of PVR, ensures that most of the vitreous is all cleared up, and ensure that you do cut the trim off the anterior flap of the retina where the vitreous tends to be densely adherent. So once the base is done, base shaving needs to be done at, I normally keep my setting at about 150 to 200 as the suction, and about 5,000 cut rate, 5,000 to 7,000 cut rate. So once all the base is cleared up, the retina is all flat and nice, mobile, comes the time when you start doing your fluid air exchange. The view tends to be a bit hazy as soon as you start the fluid air exchange. So it's always better to take in your extrusion cannula right up till the posterior most break and be there and allow the air to come in. And don't be in a hurry to aspirate off the PFCL or go posteriorly, because that would mean that you're allowing the fluid to go more posterior. I personally like to drain almost all of the fluid through the break before I go posteriorly PFCL. This is one case where this is the same GRT case where I'm doing a PFCL air exchange.
Dr. Anirudh, can you please conclude?
That fast? Okay, sorry. PFCL air exchange where you can see that I went in very quickly and I aspirated the PFCL first. So there is a retinal folds that you can be seen. I of course realized it, and then I re-injected the PFCL and done the fluid air exchange again in this case. This time trying to make sure that I remain between the meniscus of the PFCL and the air and drain out all the fluid before I proceed further. Laser, ensure that you do laser to all the breaks, but you don't have to do 360-degree laser. Don't be very, don't use very high intense burns, because they themselves can cause breaks and can lead to recurrent RD at a later stage. Tamponades, PFCL, or silicone oil or gas. Confirm once that the retina is all nice and flat, and the silicone oil injection. Again, in this case, I tend to reduce my IOP back to 10 to 15 millimeters while I'm injecting. And at about 80% fill, that's the best time to come out and sort of directly, under direct visualization, take out the rest of the air. This prevents overfilling, and you have a good control of the fill. And I think with that, your surgery is done, and my talk too. And I hope that I was able to give you some extra tips how to perform a vitrectomy, basic vitrectomy in rheumatous retinal detachment.
Yeah, thanks, Anirudh. And next talk is going to be from Dr. Venkat. By the time he loads his talk, can we have a comment from Dr. Veerbhadra?
Whenever there is a large retinal tear, actually, when you are doing a fluid air exchange, you should be very careful, because PFCL can go below the retina.
Yes.
So that should be very careful. A smaller tear, it won't happen so easily, but when it's a large tear, when you are doing a fluid air exchange, visibility will be difficult. Sometimes you will end up with some small PFCL will go below the retina and it will go to the macula. So very difficult sometimes to bringing back it after filling it. That's one point we should remember. And now we are moving from the buccal to completely vitrectomy also. But still, I prefer, I think, for rheumatous RDs, we should put some belt buccal. That will help us to reduce resurgeries.
I personally, of course, everybody has got their
Yeah,
own,
that's it.
but belt buckle is very rare from my side per se. It's either vitrectomy or I go in directly for a buckle, straight away for a buckle.
Especially
So cases, unless I'm looking at inferior PVRs, those are the cases where I end up putting.
When there is, of course, when there is a PVR, when we are not identifying few of the membranes and not able to remove, and especially lower breaks, sometime better to put a buccal.
Thank you so much.
Thank you. A warm welcome to all of you from the BOS Organizing Committee. And it's nice to see most of our friends here sitting here in this gathering. If you could play the music at the background with little volume. A drop nucleus is an era where is a situation basically that makes the retina person feel like a hero. Very rarely a retina person, when he comes out at the end of the surgery, feels heroic in spite of the heroic. Principles of a drop nucleus cataract surgery is never chase the nucleus when you go down. It's very important to clear all the round vitreous which is around it. Ensure that you have adequate support of the nucleus so that it doesn't hit the posterior pole. Reassure what you can see through. Are you able to see the visualization well? So your basically surgical method basically goes upon analyzing as to when you want to do it. In most of the situation when it's an early vitrectomy, when you can probably do the drop nucleus management right at the time of the primary surgery, it's absolutely the best time. In most of these situations, if it's a soft nucleus, you could use what is called as a hybrid vitrectomy, or you could gauge cutter. Ensure that you have complete clearance of the nucleus from with the surrounding vitreous. Ensure that you can float the nucleus, and in these situations it may be simple and directly for you to go ahead and use your phacoemulsification probe and then completely remove the nucleus in toto. The important step that you need to remember here is don't go to chop the nucleus further at this stage. Completely try to eat it up in one toto. As my friend said, Anuruddha said, check your periphery, ensure that you have done the indentation, and make sure that there is no peripheral tears, no peripheral damage. In good situation capsule, you could use a 3-piece IOL. In cases problem comes is when you actually need to manage a large nuclear fragment. You could use either a fragmentome, or you could use what's called as an intravitreal phacoemulsification itself. A fragmentome used to be something which we all learned with, which is basically a much larger kind of a probe, which has about more than 20 gauge, so you need to make a larger opening when you need to use a fragmentome. The fragmentome tip actually has a tip which is very more similar to that of the phaco tip, but except that it will produce a large more amount of shearing forces, as a result of which you can see large of nuclear fragments start getting spurted. Chances of nucleus tear is higher. When you're using a fragmentome, important to note to maneuver, most of the maneuver should be in the mid-vitreous. You could use it in the direct mode wherein you're just using the foot pedal, pressing it down to give you the maximum phaco energy. But if you could use the parallel mode wherein the phaco is activated when you're using the parallel mode, that will ensure that you're not actually catching or there is enough amount of vacuum throughout the procedure. In certain harder situations where you have a much harder nucleus, you would always want to probably float the nucleus with a PFCL and then even sometimes maneuver it directly. You could use what is called as intravitreal phacoemulsification. In these kind of situations, use your phaco probe itself. Those of them who do not have a fragmentome, you could just convert your phaco probe to a fragmentome kind of a piece. You need to remove your sleeve because you don't need an infusion in first place, and the second place you need to remove the infusion because you're having a continuous infusion line too. Now this probe is now your phaco probe is now your fragmentome probe, and you can go in through a 20 gauge enlargement and ensure the same steps. You should have done adequate staining with triamcinolone, ensure that you have cleared all the vitreous around the nucleus, use PFCL, and now you can use your phaco probe. Generally in the burst mode itself, you should be able to emulsify the whole cataract in the anterior or the mid-vitreous. Most of this can be done very comfortably with your phaco probe. In most of this, people who use Ozil technology, the chances are better because you don't not then having longitudinal effect, so therefore the nucleus is always caught well. Ensure that you have adequate wound closure at the end of any of these situations. Cases which are very harder or if you're more challenged, it should be simple sometimes to just fill the whole cavity with PFCL. Ensure that you can float the nucleus as much as possible anterior. Tunnel in these kind of situations to give you a much more stronger wound integrity, and then maneuver the nucleus more anteriorly and try to remove it. In these kind of situations where you want to probably even use iris hook and try to manage the pupil and ensure that you can deliver it through an anterior route through the small incision itself. So the management of nucleus drop is something about first not panicking, ensuring that you assess the situation. In situations where it is more difficult, you don't have adequate support, you could use an iris claw lens and ensure good pupil centration too. So there are different ways of management secondarily, either using a scleral fixated or an iris claw IOL. To conclude, you need to assess whether you are able to operate it on day one. Is there any corneal edema? How is the visibility? Or you would want to operate it subsequently in the presence of corneal edema in as many situations within the 3 weeks. Assess whether it's a small nucleus. Can you use directly your vitrectomy probe or use a kind of hybrid vitrectomy? Or you have a large nucleus, in which case you would want to use, float it to the anterior chamber and remove it. Or sometimes you could use directly in specification. Finally, it's about knowing what is the right thing to do and not to take hasty decisions and not to panic in any of these situations. Thank you.
Yeah, thanks, Venkat, for bringing out different ways to manage a dislocated nucleus. Thank you very much. By the time the next speaker comes in, one comment from Dr. Sharavanan, please.
So very nicely depicted.
Yeah, next speaker is Dr. Guru Prasad IAS, and he is going to talk on surgeries for macular hole.
So a nice video showing this thing. 2 points I would like to add is that one is to decrease the bouncing of the hard nucleus from. Use low power mode and pulse mode. As the nucleus gets harder, it tends to bounce off. So you can use the pulse mode. Again, it decreases the bouncing effect, and also use low power. Once you get a bite into the nucleus, then you can increase your power so that it doesn't bounce off your tip.
Always using PFCL is better when we are doing the phacophragomatome, and when you are using the phragmatome in a 20 gauge, the wound burn can happen, so you should be careful about that. So refer the case whenever there is a nucleus drop, and I mean heroic thing, and don't put the IOL, and I think the retina surgeon can handle better and put the IOL.
Keep in mind that the amount of heat produced at the tip is very high. So if you are releasing the ultrasound energy near the retina, it can produce large irregular breaks. It will be initially white. At the end of surgery, it will become large irregular breaks. So like you can get corneal burns and wound burns. You can also get retina burns. That's why I was commenting on the use of PFCL to protect the posterior pole. But sometimes people go and try to aspirate because the pedal does not have a differentiation between the aspiration and ultrasound energy release. Sometimes you can inadvertently press and create a beginner and you're not very sure. You can use PFCL, or always switch off the ultrasound energy, pick up the nucleus, bring it to the anterior midvitreous, and then start your. It's a very common mistake made by beginners. They release the energy and realize that they are getting big tears in the periphery.
Thank you very much. So we can have the next talk now.
Until my presentation opens, can I say something?
Yes, sir. Please, sir.
About the timing of IOL implantation. Sorry, I don't have it. So the timing, I think, depends on. Okay, we'll take it up next. I'll start off with this. So thank you, BOS, for this opportunity. So surgery for macular hole is something that is close to my heart, and I've been doing it since the time it was started. And not all holes are amenable for treatment. Outer retinal holes need not be treated at all. Lamellar macular holes, if they have an element of traction, can be treated by surgery. And FTMH, of course, full thickness macular holes, especially the idiopathic ones, can be treated with vitrectomy. So the pathogenesis, everyone knows, it's very well understood that it is the anterior posterior traction and the tangential traction caused by the ILM that causes the macular hole. And these are the different stages in a schematic manner I've shown, just to show you that the stage 1 and stage 1B need not be operated, they can be watched. In fact, they don't usually cause any visual symptoms, and this spontaneous restoration of the contour is a possibility in about 60% of cases. Stage 2 onwards is the one we are talking about today. Surgery can be offered to these patients, but that again depends on the visual acuity, the comorbidities the patient has, and the complaints to positioning that we can expect from these patients. Treatment of choice, vitrectomy with ILM peeling is the gold standard today. And of course, oculoplasmin and all that has been tried in the past, but discontinued due to the high rates of visual morbidity. Dyes have to be used because of the improved visibility, otherwise it's very difficult to visualize these, the ILM. IST has been discontinued, but it is one of the best dyes that can be used to give the best contrast. Trypan blue stains only the ERM but not the ILM. Triamcinolone stains residual vitreous only, and brilliant blue-green is the one which we use in the present day, which has excellent staining ability of the ILM and relatively non-toxic. The one important prerequisite for macular hole surgery is to create a good posterior vitreous detachment. So this is very important because unless we remove the posterior, it's possible to stain the ILM. So this is conventional peeling. So I think that video got skipped. This is peeling across the hole, which is what is preferred by many surgeons. It is supposed to give the best relief of traction. So peeling across the hole is something which I also follow in small holes. I'll tell you what I do for bigger holes as we proceed with the presentation. So this is just to show you the use of a finesse loop. This loop is actually designed by Alcon, and this is something like a DDMS or diamond dusted membrane scraper that we used to use in the past before the finesse loop was introduced. And this is to initiate the flap, which we can, in experienced hands, use the forceps for. So this is the ILM being, or this is inverse ILM peel, and the ILM is then trimmed to be just adequate enough to close the hole. Petalloid peeling is another. So this is just to show you the preoperative large macular hole that was present, and the petalloid peeling being done very much like the petals of flower. And then once the petals are arranged on the, what happened? Starting all over again. I have no control over the seat bar, so I think we'll have to put up with this. So that's the petalloid peeling being done. So at the end of the 360-degree petalloid peeling, you can see that it looks very much like a flower petal. And these are then trimmed to leave behind only that much that is required to close the hole. And then the hole is stuffed with this, so to reduce the seat bar. I'm about to finish anyway. So that is about the stuffing of the hole after trimming it. So perifoveal detachment induction is another method which we use for very large holes or failed macular holes, a hole that is not closing in spite of 2 or 3 surgeries. So this is something that we can use a 41 gauge needle to induce a detachment around the fovea and do a fluid exchange. To cause detachment of the macula itself, the edges of the hole gets detached, closes. So the results are fairly good, and we can expect these holes to close after failure with the conventional methods. And then the fluid air exchange to approximate the foveal edges. So this is something which we rarely use as a last resort. I personally don't like this method because it is a very costly material to be used for patching the macula, which depends on actually transplanting rods there. So I think we can discuss this during the discussion. The transplanted material retina is put on the macular hole, a large macular hole usually, more than 1,000 microns, and then under PFCL it is fluid air exchange is done. PFCL is slowly removed by tilting the eye towards the disc, so that the PFCL comes towards the disc, and use of IOCT also helps in these patients. So this is a case where there was a traumatic macular hole, which can see the vitreous base avulsion being removed. Fortunately, there was no dialysis. I'm about to finish. So that was PVD induction, and you can see that the peripheral hyaloid is being removed there. There was vitreous hemorrhage due to trauma. And there's a lot of subretinal blood. There's a choroidal rupture, no doubt, and there's a lot of subretinal blood. So this is ILM peeling, but what you'll see next is something that is interesting. the subretinal blood is being actually blown out using a backflash cannula. You can see that the blood is coming out from the hole. So this is one way by which we can the subretinal blood in case a hole is already there. And finally, macular hole RD. So it's not very difficult to remove the peel the ILM when there is a macular hole with RD. It is as easy as it is in an attached retina. Although you should know the direction in which to peel, and that is the peeling of ILM on a detached retina. Tamponade and positioning is something that is very, very important. And types of hole closure, I think we are all familiar with. In summary, I would say that you should know whom to operate upon. Operate early for best results, because otherwise the edges will get atrophic, the RP will get atrophic. Use proper technique, instrumentation and adjuvants. Decide tamponade based on patient's comfort and compliance. You can use silicone oil if the patient is not able to position himself. And be realistic in counseling about the outcome of these cases. Thank you very much.
Thank you, sir. That was a wonderful demonstration of different ways to close a macular hole. Request Sharona to give a comment on that. And the next speaker is going to be Dr. Naresh Kumar Yadav. He is going to speak on surgery on membranes.
So, very nice videos of the various techniques. As sir was pointing out, the graft is not a routine mode, only for failed holes or a very large holes we utilize it because, as I said, it's not it's a quite expensive material to put it. Other things we can do is we can use amniotic membrane. Some people have used fibrin glue, other adjuvants for not very large holes, but failed holes I tend to use autograft. But otherwise, very nicely depicted techniques.
Very good afternoon to one and all. So I take this opportunity to thank BOS for giving me this opportunity.
What extent we have to peel ILM and how we have to make a flap, all that is a lot of difference going on actually. So I think now inverted flap, that's what people are practicing now. So earlier we used to remove entire ILM there actually. So now we are not removing entirely there. So that's the macular hole. Most of the cases we are seeing excellent results these days. I think macular is one such thing actually. All retina surgeons enjoy the surgery.
Okay, so I'll be speaking on peeling ERM membranes. Next slide, please. Okay, so ERM, we know that is extra growth, fibrocellular growth on the macular area, and diagnosis is very simple. OCT is the gold standard, but multicolor also and photographs also pick up the ERM in a nice way. So basically, with PVD or anomalous PVD, you can get micropores in the ILM, and through these pores, the glial cells come onto the retinal surface. And some amount of hyalurocytes always remain even after a good PVD. So when these microglial cells come in contact with the hyalurocytes, they transdifferentiate into myofibroblast, and you can get a ERM. And this can contract and distort the retina. This is the pathogenesis of ERM. So basically, this is the classification. So we just have to look at whether the foveal pit is okay or not, and how are the retinal layers. So in the stage 1, foveal pit is okay, or retinal layers are fine, and in the stage 2, foveal pit is absent, but all the retinal layers look normal. And the third could be there's a continuous ectopic inner foveal layer. So inner layers are, you can see, there's no pit is seen, and they're going across the fovea. And in the last one, you can get this distortion of all the retinal layers. So this is important because this will give you a prognostic idea what to tell the patient. Because when to operate is very crucial in ERM cases. So basically, then other thing is you have to see whether it is a idiopathic ERM or you're dealing with a secondary ERM. So any ERM, you don't jump and say that it is idiopathic and you offer surgery. Because if there is a secondary ERM, you may have to take care of the secondary pathology also. So this is a child, I had seen 5-year-old child was diagnosed to have coats over a course of 1 year, had multiple sessions of laser. I did one cryo session also. Unfortunately, the patient developed secondary ERM, and the vision came down, and the patient was operated with good results. So this is another case, patient who had CRVO, there was suboptimal response even after couple of anti-VEGFs, and then the patient was taken up for surgery with good anatomical improvement. In spite of that, sometimes the edema could come back and you may have to again give anti-VEGF. But in such cases, after giving a trial of anti-VEGF, surgery is warranted. So this is another case you can see. This is a very thick ERM, very significant ERM, and the patient did well after ERM surgery. So basically, the video, no, the next previous slide, play the video. Yeah, so this is also a diabetic case. So sort of negative staining, the ERM is not stained, and then I am peeling the ILM. So most of the secondary ERM cases, diabetic, CRVO, it's better to peel the ILM also along with the ERM. So in that case, you are sure that the entire scaffold is removed, and you are sure that the entire ERM has come out. Okay. Yeah, next. Yeah, this is interesting case. The patient had undergone buccal, and after around 2 months or so, the patient had a recurrence. So you can see the superior, you can see the cryo marks, and at the fovea you see a macular pucker. Patient also underwent surgery. Play the video, please. So the macula could not be really seen also, so I'm using PFCL to open up the macula, and then I am peeling the ERM. So basically you go at the edge of the ERM and you lift it and come tangentially along the retinal surface. So that way you can remove the ERM in a better way. If you lift it directly up, it may sort of break up and then you have to regraft the membrane. So this patient also did, you can say the ERM is removed, the retina flattened well, and then I did a drainage retinotomy and gas was injected. Yeah, this is the pre and post-op. And this is another case, there's a VPT you can see in the infratemporal quadrant, and there is a ERM. Luckily for the patient, after cryo, the PVD got induced and the ERM got released. So any case of ERM, you should always look for secondary causes. So this is another idiopathic ERM. I'll just show a video. Play the video, please. So a good vitrectomy is important, and most of the patients will have PVD, but always use IVTA. So you are sure that there is no PVD remaining. And in this case, you can see there's a sort of taut posterior hyaloid. It's a very extensive proliferation, and there's a significant ERM also. So PVD is being induced. Always after vitrectomy, always have a look at the periphery. There is a high risk that as compared to other vitrectomy, macular hole ERMs, you may peripheral retinal breaks. So always inspect the retinal periphery, and then the ERM is being peeled. It came as a sheet. So if the ERM is very firmly stuck, sometimes you can stain and aim for the ILM peeling. So that way you are sure that the ERM has been removed. If the ERM is seen like that, you can peel the ERM also, or aim for the ILM peeling. Next, please. Just 1 minute. Yeah, this is just to show a complete video, please. So, no, the previous one. Next one. Next, yeah, play the video. This not playing. Okay, it's fine, I think. So this was just a video showing a jet stream break. So if you are using, many times we use staining under air, and once you are switching over from the air to the fluid, always reduce better to use walled cannula. If you are not using walled cannula, it's a non-walled system, and you keep the IOP at 30, the jet stream can cause breaks. So you have to be careful. But most of the time, I think staining under the saline is good enough. And the other complication is phototoxic maculopathy also. So always hold the light pipe a little away tangentially, and if you are staining, don't keep the light pipe there, always come out. So you have to be careful. Otherwise, a good surgery, you may end up with a result like this. Okay, thanks. for
Thank you, sir.
patient hearing.
A wonderful way to demonstrate how to peel the idiopathic and the secondary apparietal membranes and taut posterior highlight. Next talk is going to be by Dr. Mahesh Mugam on the art of scleral buckle, and one comment from Dr. Sharavana.
One thing, a lot of people are that confused is whether to do a ILM peeling along with the ERM peeling. So, like, what are the cases where you would do a combined ILM or only the plain ER?
See, multiple studies have shown that there's not much difference in visual acuity whether you peel ILM along with the ERM, but sometimes I usually, if the ERM is very firmly adherent, there's no gap between, on the OCT will give you idea whether there's a gap between the ERM and the retinal surface. When you're finding it difficult, then you can, along with the ILM, you can peel the ERM also. The combined could be, or in secondary, if it's a diabetic CRVO, in such cases. If it's an idiopathic ERM, I think just peeling the ERM is good enough. You don't have to really go for ILM peeling. But many times, if the ARM is taut, it itself will scroll the ILM. So once you stain it, you see that the ILM is very easily visible. And in that case, you can.
Thank you, sir.
I can start. So thank you so much. I'll be speaking about the art of scleral buckling. I'll show a couple of cases where we mess up the buckle and then how easily we can turn it around, and also some special cases where only buckle worked. So here we have a large posterior break and lattices, and we buckled it like this, and we find that like we messed up a little bit. The posterior part of the break is not covered. So what we can do is we don't have to revise the whole buckle. So you can kind of slip a small piece posterior to the existing buckle, so that supporting the break which was missed to be supported in the previous one. So how do we do it is like we just take an existing buckle and then cut off this segment. So the rest of the segment we insert it under the existing buckle. So that's what we do. That's what has been done. So how do you take a suture? So here you can see a modified technique of taking a suture. So anterior bite was taken radially. The posterior bite is being taken circumferentially. What you see there is the inferior oblique insertion. So avoid that and take 2 bites on either side. And again, like here, anterior, we're taking it through the root of the muzzle insertion. So this way, it's easier to take a, and you can extend the buckle posteriorly to cover that break which was not covered in the previous buckle. So here we used to do 360 degree, 279, 280, but then we don't do that anymore. We use the 42 band. So 42 band is like 4 mm in size, in width. So we can use the crescent, double the width of the crescent is adequate to thread the 42 band. And these are atrophic breaks, and they are not HSTs, so it's easier to support them, and the formed vitreous inside closes the break, and it's adequate enough to reattach these detachments. And then, like in this particular patient, you can see the 42 band is not going, it is not supporting the superior temporal break. So we can do a modification of placing a solid silicon under the 42 band. But as you know, the solid silicon is a 279, which has got a bed of only 2.5 millimeters. So we make it to accommodate the 4 mm band. So we kind of carve out the trough to support, to place it under the 42 band. So only the superior temporal quadrant where that break is not supported, you can still do a sutureless buckle, place it there, but then like this was a 42 band which is not this properly. So the tunnels are in place properly. So we make make the sutures and make it as a suture buckle. So you can modify the 42 band along with the solid silicon as well. So this is the post-operative appearance. You can see quite a posterior buckle effect, and this is at 1 month post-operative. So we can use viscoelastic to augment the buckle as well. So in addition to doing the techniques what I already showed. So here it's a kind of a very extensive traction, significant traction is there, but still a buckle can be done. So we place the tunnels, we drain the fluid, and we have placed the solid silicon also, buckle effect. So radial circumferential incision is made, and through that we are injecting the visco in the suprachoroidal space. So you have a suprachoroidal increased buckle effect in addition to having a solid silicon also. So scleral buckling can sometimes be done in retinoschisis. This is a juvenile X-linked retinoschisis. You can see the schisis here. And once we are able to identify the outer retinal break, that's good enough to be buckled. But here the break was quite posterior. So this is how we do a radial buckle. So you can see the sutures are placed radially, but then what we are creating is an X-shaped suture, not a box suture, posterior to anterior. So this X-shaped suture, you cut it and convert into a box suture. And we can place a radial buckle here so that you can go as posterior as possible, and in the process support a posterior outer retinal break in a retinoschisis. This way we can get away by not doing a vitrectomy, then subsequent cataract, oil, all that we can avoid by doing a radial buckle. Not in all cases, wherever we are able to identify the posterior break. So this is the post-op appearance. You can see the retina is attached. So buckle is possible anywhere. Here's another situation, a 35-year-old lady, HIV positive, one eye was lost because of chorioretinitis. The scar was involving half the retina, disc and macula was within the scar. This is how it was. So there's no way we can do a vitrectomy and save this eye. So here we went ahead once again with the buckle. As you can see, so posterior, it's about 2 diameters from the disc is where we are doing the buckle. So once again, a drainage and quite a posterior suturing. So the suturing can be a bit of a difficult, so posteriorly, but despite which we managed to place the buckle there and take the sutures. And this is the only way we can save this eye. Like the retina is attached and she has got ambulant vision post-operatively. So another situation where we can do a modified buckle is a recalcitrant hole macular buckle. So here you can see a high myopia with a peripapillary staphylomas, and so this is the T-shaped macular buckle which we are placing. This macular buckle actually goes under the lateral rectus so that we can alter it to go right under the macula. Can take sutures through the buckle and secure it to the sclera. And the other arm of the macular buckle is also secured. And then the encircling band is tightened. And the T-arm, the posterior part of the T-arm goes over the posterior part of towards the macula, and that's the macular hole. So that's the encircling band being tightened. I can see the macular buckle is right out there. You can see the staphyloma is closed and the retina, the hole is closed. So similarly, instead of doing a buckle, you can do a scleral imbrication. Instead of lengthening the retina, we can shorten the sclera. Once again, this was a patient where there was a high myopia with a failed macular hole, multiple vitrectomies had been done, and a posterior staphyloma. So here we can create a bed and shorten it by taking sutures through that. So where there is redundant retina, you shorten the sclera so that it kind of flattens out. So this is the postoperative appearance. You can see the staphyloma is flattened out and the hole is closed. So SB is where science meet art, and thank you all for your kind attention.
Thank you, sir. And that was a wonderful demonstration of different ways to put the retina back using a scleral buckle. The next talk is going to be by Dr. Ramesh on the new molecule that we have in management of NAMD and DME. Comment from Sharavana, please.
So as sir actually pointed to the heading itself that it's a lot of sort of a dying art. A lot of people are young people are not taking a buckle as it should have been in the earlier days. So even though it's not like as easy as a vitrectomy, because you see everything in a vitrectomy visually, in buckle you have to do a lot of guessing work. So if you can learn from all these senior mentors and get that, imbibe that process, then you can start learning yourself. Failures, but you keep persisting and you'll get the hang of it, and it will be a good way of managing some cases like young patients where you don't unnecessarily create a cataract in a young kid and all those things. So it's a good thing to learn, and even though it's a little bit difficult in the earlier stages, once you get the hang of it, it's not as bad, as difficult as it looks like.
I think preoperative assessment is also very important, and identifying the breaks and proper planning is important in buckle. I think as it is mentioned in the presentation, it's an art actually. I think everybody should learn. I think most of the retinas are well, except these days people are thinking going for only vitrectomies. So,
Yeah, thanks for that. Over to you, Ramesh.
Yeah, thank you to BOS for giving me this opportunity, and Roche for giving, this is a sponsored talk, and this is basically going to be the non-surgical talk in a surgical session. So I'll be speaking about Vabysmo as the first line treatment and optimizing its outcomes in neovascular AMD and DME. And this is the disclaimer slide. And neovascular AMD and diabetic macular edema are the most common causes of vision loss for choroidal pathologies and retinal vascular pathologies, and we know that both are pathologies. So when you look at the treatment for both these entities, it is anti-VEGF, which is the treatment of choice, and we have a host of molecules right from Macugen, ranibizumab, aflibercept, and brolucizumab, which have been used in the treatment of these choroidal and retinal vascular diseases. But the latest which has come to the block is the faricimab, which is being approved, the most important molecule which comes for the approval for neovascular AMD and diabetic macular edema. And as a clinician, the minute you have a new entity which comes, or a new molecule will comes into the market, the first question you ask is, what is so special about Vabysmo, and why it is just another anti-VEGF molecule, what we all think. But in today's age, when you have any new drug which comes for treatment, you always have to prove that drug B is better than drug A, and there is another aspect to drug B, which is in terms of looking at what is the duration of action. So you always have to prove for any particular drug that is there any additional mechanism of action, and is there any longevity of the duration of the action. So in today's day and age, when you look at Vabysmo and compare it with any other anti-VEGF molecule, you know that it has got this additional mechanism of action, which is called as the Ang2 inhibitor. The second aspect is the longer durability and the reduced dosing frequency, which is the additional part about Vabysmo. So let's understand the Ang2 mechanism more properly. And you know that in healthy tissues or in a healthy retina, it is the ratio between the Ang1, the Ang2, and the VEGF-A which leads to the vascular stability, and that inhibits the vascular leakage and the proliferative process. But the minute you have a diseased retina or you have a pathological stage, the Ang2 supersedes the Ang1 production, and the VEGF, there is upregulation of the VEGF pathways, and therefore now there is occupies the space which was initially occupied by Ang1, and that leads to vascular instability, leading to both Ang2 upregulation and VEGF upregulation, leading to vascular leakage, neovascularization, and inflammation. So when you look at these cases where you have compared the Ang2 levels in control patients versus in the disease state, you'll always realize that the Ang2 production is much superior or much more than what you have in normal vitreous samples. So faricimab is basically a bispecific monoclonal antibody molecule. That means it acts specifically Ang2 levels, and also acts against the VEGF production. And because it has got a modified Fc fragment, it prevents inflammation, intraocular inflammation, and reduces the systemic exposure as well. So this dual action is what faricimab is being known for. But when you compare aflibercept does not suppress the Ang2 levels in patients with neovascular AMD or DME, and this is being very nicely proven with these slides, where with aflibercept the Ang2 levels don't go down. Now, whenever you have a new anti-VEGF molecule which is come, you always this is one is efficacy, safety, and durability. And for efficacy of any anti-VEGF molecule, for neovascular AMD, this is where I try to look out. I look for the improvement in visual acuity, the reduction in the macular thickness, the percentage of patients who are showing reduction in PD, SRF, IRF, and the percentage of patients who are showing reduction in the CNVM leakage or the polyp regression, and percentage who are going to lose vision due to RP tear or subretinal fibrosis or RP atrophy. But in addition, when it comes for a DME patient, you basically are trying to look out whether there is percentage of the patients where the macular vessel leakage is how much reduced, and patients where they are showing hard exudate resolution. So to look into these trials, due to understand the efficacy, you have these two very important trials. One is the TENAYA and LUCENT, which is important for the age-related macular degeneration, which is basically comparing the 6 milligram faricimab versus the 2 milligram of aflibercept, and you are trying to look in terms of the visual acuity gain at 48 weeks, where you can see that the visual acuity gains are almost comparable to that of aflibercept 2 milligrams at 48 weeks. But when it comes to CSFT reduction, the CSFT reduction is also comparable at the 40 to 48 weeks, where it is almost similar to that of us, proving the point that faricimab is non-inferior in terms of visual acuity improvement and in terms of reduction in CSFT compared to aflibercept 2 milligrams. Now let's look at what's the improvement in the anatomical improvement which you have, and you will see that the proportion of patients who are treated with faricimab, they show higher resolution in terms of reduction in the SRF and the IRF in the TENAYA and the LUCENT study. And when you specifically try to look at patients with PCV, you almost get similar results, where the polypoidal regression is much better with the faricimab group compared to the aflibercept group. Let me also show you some cases. This is a 71-year-old female. She's basically an ophthalmologist's wife from Indore, and she is complaining of blurred vision with a visual acuity of 6/12. And you can see that there is a very early neovascular AMD, which is a type 1 CNVM. And look at the OCT scans which are there. The top left is the one which is at presentation, where you have a type 1 CN with overlying STREM and a neurosensory fluid being treated with as per the TENAYA and LUCENT study, where you are giving the monthly loading dose therapy for 4 consecutive injections or 4 consecutive months. And you can see at the right bottom, on the right side bottom, you can see this is after the 4 injections of faricimab. The case 2 is a case of PCV, where you can see there is a bilateral PCV which is present at presentation, where you can see on the ICG the polyps being there, and this is after a single injection after 1 month of Vabysmo, where there is an improvement and reduction in the fluid activity, and also the polyp, the PD heights are reducing. So when you talk about DME or diabetic macular edema, what comes in mind is the Yosemite and the Rhine studies, which again talks about comparing faricimab 6 milligram in a Q8 dosing versus faricimab as per the personalized treatment interval, and aflibercept 2 milligram 8 weekly. And you can again see that the visual acuity gains and the CSFT reductions are almost comparable to that of aflibercept at year 1 and maintained through year 2 as well. Now, what's important in a case of diabetic macular edema is the macular vessel leakage, and you will see that in the Yosemite and the Rhine study, you will see that the proportion of patients where the macular leakage has reduced is much more than with the aflibercept group. Now, let me show a case of diabetic macular edema, which we treated faricimab. This is a 62-year-old male, type 2 diabetic since 15 years, well controlled with an HbA1c less than 7% and a visual acuity of 20/30 in both the eyes, and he complains of blurred vision. Look at the fundus photographs. You have a typical moderate NPDR with a CSME line of picture, and look at the OCT scans to start with. This patient has been treated in the next 5 months with 8 injections of ranibizumab, with 4 injections in each eye with a regular dosing. And when you see, these are the middle images are the ones which is the center involving diabetic macular edema pre-Vabysmo for the right eye and the left eye. And what you can after single injection of Vabysmo is that at 6 weeks there's a total reduction which is even maintained at 12 weeks for both the eyes. When it comes to safety, the second important parameter is safety for any anti-VEGF, and what you try to look for is the detection of any intraocular inflammation post-injection, which can be in the form of anterior segment and posterior segment. And the reasons for posterior segment have to be for looking out for vitreous cells, vitritis, vascular occlusions, vasculitis, and cystoid macular edema. And you will see that in the TENAYA and LUCENT and in the Yosemite and Rhine study, faricimab was well tolerated, and even this slide very clearly tells that despite having more number of injections, you really don't have a significant number of cases with retinal vasculitis and vascular occlusion. The most important aspect which faricimab was sold for is for the duration of action. And when you try to look at duration of action, you look at the Q8 dosing, the Q12 and the Q16 treatment-free intervals, and you will see that more than 80% of the patients were able to maintain at Q12 in the TENAYA and LUCENT, and even similar results were seen with the Yosemite and the Rhine study. Let me show a case which is again a case where we gave faricimab for a patient with CRVO, where this patient was being treated with multiple injections of anti-VEGF, almost 20-30 injections of brolucizumab, and this was the clinical presentation of the patient in 2019, treated with PRP and multiple injections of anti-VEGF and steroids. And then you will realize that This is pre-Vabysmo. The top image is a pre-Vabysmo cystoid macular edema, and this is post-Vabysmo at 12 weeks where the macular edema is resolved. Let me just talk about in a few slides about the experience of Vabysmo at Narayan Nethralaya from Jan 12, 2024, where we have given 68 injections of Vabysmo in 34 patients of 41 eyes, where most of the cases have been treatment switch cases, and you have a significant proportion, which is 20% of treatment naive cases as well. If you look at the indications, the most of the indications have been for neovascular AMD and diabetic macular edema, and a few of the eyes have been for retinal vascular occlusion. So you can see with this slide that there has been a significant reduction in the CSFT 1 month after the Vabysmo injection. When you look at the PED resolution, what we found is that there has been a 35% cases which showed the PED resolution at 1 month, 68% cases showing SRF resolution at 1 month, and 52% of the cases showing IRF resolution at 1 month. We have patients with ranging from 0 to 5 months follow-up intervals. And what we found about the durability, this is our experience, where we find that in 38% of the cases, the durability was for 2 months. We had 10% of the cases where it was for 3 months, and 4% and 8% of the cases where it was for 4 months. So when I will say that faricimab is a bispecific antibody against VEGF-A and Ang-2, its efficacy is as similar as aflibercept 2 milligram. Safety issues are not concerning at this point in terms of vascular occlusions and vasculitis. And the treatment intervals, treatment-free intervals are long, with more than 75% of the patients having Q12 and Q16 dosing, both for AMD and DME. Thank you very much.
Thanks, Ramesh, for talking about your experience with Vabysmo and the science behind it. Our next talk is going to be from Dr. Sharavanan, and it's a keynote address on managing a diabetic TRD and combined retinal detachments. So by the time he sets up, can we have a comment?
Today's
on
most of the
Vabysmo?
panelists are really good surgeons in Retina, actually. That's really good. Actually, we should appreciate, I think, the organizers, especially Dr. Karthik Meda, I think, selected or requested good people to present here. I think, as I know, Dr. Saravanan is one of the best surgeons in the country. I have seen his excellent surgeries. So, very happy to listen from him.
Yeah, his initials itself says it all.
Thank you, sir. Thanks, Veerbhadra, and loss of vision over a period of months. So better to operate them once you identify that the nasal traction is happening. So don't look at the fovea and get sort of cheated or. So when you see an advanced case like this, there are two ways of going about approaching this case for surgery. One is the outside-in technique or the inside-out technique, approaching the membranes from inside out to outside in. The pluses of inside out is that you can get into the surgical plane immediately. It works for simple membranes, and sometimes in eyes with no PVD, it may be an easy thing to do. But the minus that high risk of bleeding, high risk of tears, and you may need to do bimal surgery earlier. Outside in is the usual standard technique for tough membranes because it preserves the stiffness of the membranes, and it is easy to get into the plane and do all these things. Just showing a small example of how to go about in a case of a no PVD young patient with IDDM patient. So you're starting from the middle. Rather than pulling the disc, sometimes you can get significant bleeding like you get in this case. So to avoid that, you start, even though it's from center to periphery, it is more side sort of peripapillary, so that you don't cause disc bleeding, which can sometimes complicate things. So this is how you do a center out technique, inside out. And if you are doing the outside-in technique, the critical thing is to identify the second membrane. Like you can see in the OCT, that is the PVD, and the subtle reflective layer which runs across the retina is the second membrane. And it can be tightly adherent like in the previous case, or loosely adherent like in this slide, which you can see that it's not as tightly adherent like the previous these things. And this is a vertical scan running through the macula. You can see the second membrane extends from the superior arcade to the inferior arcade totally across the macula. Sometimes it can be easily missed, which can produce secondary ERMs in the posterior pole later on after the surgery. So here you can see that once you induce a PVD and cut and trim off the vitreous, the next thing is to use, in a tightly adherent membrane, use a sharp pick like the needle, like a bent needle, to identify and pick the second membrane. So once you identify that, then you can use your forceps to go about and reflect that and peel this. So the sharp needle like this is a very critical to identifying very stiff and strongly adherent membranes. So sometimes in the loosely adherent membrane, just with suction only you can use this. You can see that once I raise the second membrane, is a little bit farther off. With suction only you can introduce your cutter into the space,
And what looks like a plaque addition actually becomes multiple point additions. So again, showing one more example of using the sharp pick to identify. So you can see your membrane extent is here, but once I start peeling, you realize that the extent is slightly further off. And once you identify the second membrane, the risk of getting additional tears or uncontrolled bleeding becomes very less. So put some effort to learning this technique to identify the second membrane. And once you can get that, now you can see that the second membrane is slightly farther off. I move my pick to where it is there and then go ahead and peeling this. This is showing example of arcade to arcade second membrane in the case of vitreomacular traction in a 1/8 patient. You can see the central cyst, vitreomacular cyst, as you can see the traction with a large foveal cyst. So you can see how transparent it is. Initially, I did not feel that it was not there, but once I realized that I was not able to empty, I realized that this was full second membrane extending from the inferior arcade to superior arcade. So it's very transparent, so you have to put some effort into identifying this. Otherwise, you can get a blowout of the VMT into a full thickness macular hole. So again, these are the old techniques used in the 20 gauge era, the segmentation, delamination, en bloc technique. And in MIVS, we have these three techniques, the conformal delamination, fold back, and the lawnmower technique. So en bloc technique, as described by Steve Charles, you can see the first is you just make a small rent in the posterior hyaloid, approach the subhyaloid space, detach all the additions using a scissors, and then remove the block. The first you release all the traction and then remove the vitreous. This is the en bloc technique. In segmentation, where there are tough membranes, where you feel your surgery is going to produce a lot of tears, just break the membrane to multiple big islands and leave them, so not removing, but it's not a good technique and hardly followed now. This is the three techniques you are using, the MIVS era, conformal delamination, where the cutter directly faces the tissue. So just to introduce and cut it directly, but this can be an issue when there's a mobile retina, so you have to give short bursts to prevent cutting the retina. And the fold back technique is where the cutter is facing opposite to the membrane, so that the tissue has to fold back and go into the cutter mouth. Example of a fold back technique where the cutter is facing away from the edge of the membrane, so that the tissue has to fold back and go into a cutter. So this is just showing the lawnmower technique where in a flat membranes, you can just use the cutter to cut the vitreous along the. So this is called the lawnmower technique, where the cutter just cuts along the surface of the retina. So what they call is the lawnmower technique, just to show the various terms used in surgery. When you're approaching combined mechanism RDs, it's not always difficult. Some cases are quite simple. You can see here there's only a small addition at the disc and at the temple to the macula, and you can see a small, which is the cause of the combined mechanism RD. But not all combined mechanisms are as simple as this case. So in other cases, you can have like a shallow RD like this, where you may have to use your forceps more because the retina is mobile. Using cutter can be a little bit difficult. Sometimes you have to use your forceps and scissors more than use your cutter. And when there's excessive fluid where the retina is very bullous, sometimes you can release the, drain the fluid from the pre-existing macular hole, make the retina a little bit more flatter to get easy access to all these membranes and do a little bit more simpler surgery. Sometimes you can use PFC also. So in these cases, you may have to use a bimanual technique to sometimes deal when the retina is very mobile. Just showing the presence of a second membrane in a combined mechanism RD. So sometimes it gets missed, so it can lead to significant PVR later on and failure of RD. So again, you can see the pick is coming into play. So once the pick is able to identify the second membrane, then you can introduce your forceps or cutter depending upon the situation. And then you can see this membrane is going across the macula. So you can see this here, you can see the second membrane is going across the macula. So if you don't address this, it can form thick membranes 3 to 4 months after the surgery, causing recurrence. That's about what I wanted to talk about. Thank you for the attention.
Yeah, thanks Sharvana for such wonderful set of videos. The next video demonstration is by Dr. Rajesh and his team. By the time they set it up, one comment from Dr. Maheshan Magam, please. About the talk from Dr. Sharvana.
Yeah, Dr. Sarunan has very comprehensively displayed all the techniques which can be done, and it's a continuum, as he mentioned right now. We don't use segmentation, delamination now. So one other thing is we should not have a cutter fixation. Whenever you think that like a bimanual surgery is required and use scissors and the forceps, we need to use that. And identification of the second membrane is of paramount importance.
We had one case for each presenter, so because gunshot wound was lack of time. So good afternoon, everyone. This is a So good afternoon, everyone. A one-eyed patient who underwent a buccal and vitrectomy with silicone oil and was referred to us because the patient was developing hypotony. So initially a port was made and with an infusion line for silicone oil. Traction suture was taken and the eye was turned downwards to expose the area. We noted a buccal intrusion. Local conjunctival peritomy was done and exploration was done. Then the buccal was carefully retracted and we noted a wound dehiscence. So after that, suturing of the wound dehiscence was done.
Actually, it had to be a question to the presenter, sorry. So, sir, would you, I mean, what different you would have made or something else?
Yeah, I think all precautions you have taken of putting in the oil infusion, because this patient already has an oil inside the eye, correct? So, but then this has to be corrected because the patient has got hypotony, so obviously there is leakage going on there. So you could have probably kept a scleral patch graft ready and take the anterior bites just before we open up the buccal, so that like the graft is in place. Other option is probably to glue. I don't know how, with the oil coming out, glue may not have worked. So anteriorly you can take sutures and keep the flap ready and take the bites through the anterior to the scleral flap as well, the graft as well. Then remove the buccal and then quickly place it down, close it.
So would you remove, now that the retina is flat and stable other than hypotony, and it's been almost 2 years, would you remove the oil right now or as a secondary procedure after this?
Right now I would not probably remove the oil because like there are too many variables right now. We don't know if there is going to be a retinal break around this area where there is a dehiscence and if there is a scarring around the retinal defect. So there will be usually cryo, but if this is not the original side of the break, then the cryo scar may not be there. So I would probably wait to see whether it needs additional laser or something like that and do oil removal as a second procedure.
Did you suspect just a hypotony made you suspect there is a perforation or? Okay.
We have had another patient like this, like a one-eyed patient where the patient is sitting down, you won't see oil. The patient is lying down, the oil will come back inside. So the oil will keep going out and in, out and in. So that patient, again, we did the same thing. There were many, many years ago. You were asking about antibiotics, but this is covered by the conjunctiva. This is not opened by the conjunctiva. So I would not use antibiotics in this case.
Sarunan sir,
So like all intrusions need not be addressed unless there are complications like a RIA or hypotony. How to address this? If sometimes if it's a very small defect, we can use the capsule of the buccal which is there. You can use. Otherwise, as you showed, you can use the cadaver sclera as a supporting material. But otherwise, this is what I would also normally do. I would not attempt to remove the oil because we want to know what is happening with hypotony, whether RIA, RD, all those things are happening. So with so much going on, removing the oil at this critical juncture would not be advisable.
next question for a RD patient is, this is a operated referred CRD patient. What are your indication that you can take up a case for resurgery?
So it's a RIA-RD under oil.
Yeah, this is a diabetic CRD which was operated and subretinal oil, epiretinal oil everywhere with a recurrence with this right off. And
so we look at what is the one-eyed status and the possible visual prognosis which can get. Then I offer the question to the patient himself. So first things I should feel that I should be able to get this anatomically attached on table. If I have that confidence, then I offer the question to the patient and then make him decide actually.
Yes.
only the nasal retina is attached and the entire temporal retina is lifted up with membrane still attached to it.
So after the bimanual membrane dissection, pre-retinal heme and the PVR peeling was done to the extent possible. So due to the intrinsic contraction, the retina was not settling, so a relaxing retinectomy was performed. So PFCL was put to flatten the retina, and endo laser was done.
Since this macula was still attached, the patient at last got a vision of 618. So, I mean, any of the complicated areas, you had rightly suggested, sir, that we, if at all we can flatten the retina, it is a worth taking. And this is a young patient of 46 years. So that was the only way to go about it.
Doing a retina peripherally will help actually the traction. Otherwise, it won't settle down.
So I have to apologize to Rajesh. We had 4 more cases, but because of the running short of time, we are closing the session little early. Apologies to the next session too. And we had a wonderful session, and thanks to all the speakers and the panelists, and thank you very much.
Okay. We are going to start a session on glaucoma now, persisting beyond pressures. Our chairperson is a well-known face in field of glaucoma, Dr. Gauri Murthy. Ma'am, kindly come on to the stage. We invite co-chair Dr. Meena Menon, who heads glaucoma department at Shankara Eye Hospital, Marathalli. And moderators will be Dr. Shilpa and myself. Thank you.
So without wasting much of time, we'll just move on to first talk for the session. It is on medical management of glaucoma by Dr. Meena Menon.
I welcome Dr. Nishat Sultana ma'am, who is HOD at Minto and heads glaucoma department as panelist. Dr. Nishat ma'am. I also welcome Dr. Satyalakshmi MH, professor at